And the next lecture, last but not least, lecture of Professor Dік Буркхард, Professor Director of Department of Ophthalmology in Ruhr Hospital, Innovations in Cataract and Mixed Surgery.
Thank you so much for the very kind introduction. Slava Ukraini. Mi s vami. I'm going to talk about innovations, and here are my financial interests. And we're going to talk about capsulotomy techniques and IOP sensor technology. We all know that the continuous circular capsulorhexis is very nice, but is it the evolutionary endpoint? There are many steps involved, like centration, circularity, the correct diameter, and so there is a desire for automation. We have different devices in capsulotomy, as you can see here, and I'm going to talk about capsule laser and femtosecond laser technology, starting with capsule laser. It's a solid-state laser of 590 nanometers. It's directly attached to the microscope, fits to all microscopes, has a protection filter in it, and is easy to maintain. And you can dial in the diameter you want, and after staining you can do the capsulotomy here, as you can see in the right focus. Here's the surgical video of it. It's as you can see, that's the case is already done, and the technology has been improved over the last years tremendously. The scanning electron microscopy shows wrap of amorphous collagen, as you can see here. Initial results were very promising. What I can say with over 400 treatments, it's easy to install, it's user-friendly, you can dial in any diameter you want, but open questions remain because there are only few publications. What about the implementation time? That's an additional time involved. What about centration and special conditions? And what I can definitely say is a posterior laser capsulotomy, unfortunately, is not possible. So we are doing a prospective trial in our clinic with more than 100 eyes and have already close to a finish. The femtosecond laser technology has also improved in the last years. As you can see here in a case series, the vitreous loss was comparable between LCS and manual. But you have with femtosecond laser the good help of the scanned capsule to perfectly center the capsulotomy. It also helps in lenses which are under high pressure. You do a very small mini capsulotomy of 2 millimeters, and then the pressure is released, and do a second capsulotomy as a perfect capsulotomy. Also be aware that if the posterior capsule breaks, for example, it's nice to have capsulotomy for allowing optic capture in sulcus implantation. Also, it opens up, of course, the world of femto-IOLs. On the left, the masked non-dysphotopsia IOL, or other technologies, including the femtos, where the lenses are fixated in the anterior capsule. What is very interesting is, of course, the use of the LCS in pediatric cases, which is possible because of the small interfaces. And the cut quality is unbelievable good, what I can say. And also you can align the posterior capsulotomy to the anterior capsulotomy. What you can see here, also you can use it in non-dilating pupil, what is not so rare in this population. And what we recognized is that the capsulotomy enlarges, and found that there is an age factor. The younger the patients, the greater the extension, and we have published the Bochum formula in order to predict the final capsulotomy beforehand. It is very precise. Then, of course, what is also a good fit, perfect fit, is back in the lens technology, especially in the pediatric groups, where both capsules are implemented in the rim, which you can see here in the scanning electron microscopy of the optic. And this is how it looks like. It has really a lot of advantages. You don't need to do an anterior vitrectomy in these patients, and we'll never see PCO. So in conclusion, the femtosecond laser capsulotomy is fully automized. With the SD-OCT, it really allows and provides valuable diagnostic information. It's safe. It guarantees, if appropriately used, 360-degree optic overlap in all cases. It serves as guidance for toric IOLs and offers reliable anterior as well as posterior capsulotomy, centration diameter with excellent cut quality, and facilitates pediatric and intumescent white cataracts. With back in the lens, it keeps the anterior highlight intact, and is nice to have as an optic capture and secondary IOL implantation. Opens up the world for femto IOLs with minimal complications and improved outcomes. Also, what is really interesting is the primary posterior laser-assisted capsulotomy. What you are doing is the case is done after the cataract surgery, eyes is closed, and what Marita Scheuer-Schulz in her 3rd years of residency is doing here, she redocs, rescans, and reshoots and performs a PPLC, and this can usually be done definitely below 1 minute as an additional time, as you can see here, because there is a space between the posterior capsule and the IOL and the vitreous, because there is a fluid movement in this space, and so these entities are separated, and it can be done in nearly all cases. Here you see that there is no special program so far, but that's what it is and how it looks like through the microscope. The posterior capsule is on the anterior vitreous and disappears not into the vitreous, but somewhere else. This is how it looks like in multifocal IOL. And here, after rescanning, the anterior vitreous is intact and the posterior capsule is sitting on the vitreous and disappears. This is at the 1 hour day of surgery. Safety in PPLC over 6 months was great, including macular OCT and IOP, flare, etc. Also, after 2 years now, we had no single PCO case. So what I can summarize is that it's really easy to include at the end of the procedure, especially interesting for refractive lens exchange with multifocal IOLs. It does not need any manual capabilities. It's safe and keeps the anterior highlight membrane intact. And there was, so far, with more years now, no PCO, but there is a need for additional click fee, as well as there's no dedicated program. The last topic is IOP measurement, and there is a chip available that's called the iMate. It has already CE mark and an NUB, which means that in Germany, patients, the costs are taken over by the insurance. And you can see that it can be implanted in different locations. It's the size is 1 to 2 millimeter, only very small chip. It has no battery, and telemetrically is the IOP measurement is conducted, and it perfectly fits to the Goldmann applanation tonometry, and can be combined with mixed procedures. Here on the left side, you can see the implantation of the mini chip next generation in conjunction, followed by, so to say, by mini eject implantation, which is a silicone implant, and the chip is implanted first and offers perfect information about long-term IOP. Also interesting for post-keratoprosthesis, keratoplasty eyes, where we know that IOP is not possible, measurement is not possible, or very difficult. It was well tolerated and in good comparison to other devices, measurement technologies. It offers short and long-term information and real-world IOP. That means you can exactly check, and the patient can check the effects of topical antiglaucomatous drugs, or the effect of lasing, or whatever we do with these patients. And 24-hour IOP monitoring can be conducted at home, offering circadian IOP information. And there is a nice pipeline involved. There is a smart IOL with the integrated sensor on its way, currently in trials, and then the sensor directly will make a closed loop with the mix implant down the road. So in conclusion, these new technical aids I showed you, capsulotomy, as I said, and continuous IOP measurement chip, allows us individual diagnostics and treatments that are more, so to say, on focus, offering new insights with the aim of better care. And I'm convinced that we are caring better with this. Thank you so much for your valuable time and attention, and have a great Congress.
Thank you very much, dear Professor Dік Буркхард. And I think that this session of lecture is finished.